Good afternoon. I'm Sharon Shire, Head of Product Development at WPA, and it's a real pleasure to welcome you to today's webinar, Dispelling the Myths of the Covid-19 Vaccine around the impact on women's health, fertility and pregnancy. The vaccine continues to receive lots of media attention, especially of late regarding blood clots in the young, and we have three fantastic women here today to discuss the issues. Before I go on to introductions, I just want to highlight there will be some time for questions at the end. If anything springs to mind, click the questions tab in this window. If the window is not there, click the white arrow on a red background and it should appear. If we get lots of questions, I will try to group them to make the most of your time. Now, turning to introductions, we are very grateful and welcome back Professor Dame Leslie Regan, who was part of WPA's Women's Health webinar last year. Leslie is the chair of the WellBeing of Women and instrumental in the 2019 Better for Women report and the recent president of the Royal College of Obstetricians and Gynecologists. We're very grateful for Leslie's time today and for introducing us to two of her colleagues. Leslie, I'll hand over to you to introduce your colleagues and perhaps to help us understand more on this fascinating topic.
Thank you very much, Sharon, and welcome to everybody who's joined this webinar, and thank you to WPA for hosting it. As Sharon was saying, my name's Leslie Regan. I'm an obstetrician gynecologist and immediate past president of the Royal College of Obstetricians and Gynecologists, but I'm really speaking to you today in my role as the new chair of WellBeing of Women, the charity that funds research into every aspect of women's health from cradle to grave. And over the last year, which was being blighted by COVID, the WellBeing of Women charity has given a lot of thought about what we want to do going forward. And we feel that in addition to funding crucial research and training the next cadre of researchers who are as passionate as myself and my two co-presenters today feel about women's health, we also want to get into the role of improving the information that women receive about their health, encouraging them to be part of the solutions to their health and acting also in an advocacy capacity. So it's an absolute delight to be presenting to you my two colleagues, Professor Marion Knight, who's Professor of Maternal and Child Population Health at the University of Oxford, and also Professor Lucy Chappell, who's Professor of Obstetrics and a National Institute for Health Research Professor, and who's based at King's and St Thomas's Hospital. And I'm delighted to introduce them, not just because I consider them to be my friends, and there were two women that I've worked with in the past, but because they really are extremely expert in this field. There's nobody whose advice I would value more than Marion's and Lucy on this particular topic, because they've both been really at the front of trying to understand what's going on with the COVID-19 disease, and also now the vaccine rollout and the impact this is going to have on women's health and fertility and pregnancy. So it's fantastic that they're with us today, because I know they're going to make a wonderful job of dispelling the myths. Now, I'm going to stop there because you don't need to listen to me introducing people. What we really want to hear about is from Marion and then from Lucy, and then, as Sharon explained to you all in the audience, with reserved time at the end to address your questions. And we've also got some questions that some of you have pre-submitted. So Marion, without further ado, you're going to really set the scene about COVID-19 and pregnancy, what you need to know. Marion, the platform's yours. Thank you so much for coming.
Thank you very much, Leslie, and thank you for you as the audience for your interest in what obviously, as Leslie has said, for us is an extremely important topic. I've entitled this talk deliberately COVID-19 and pregnancy rather than COVID-19 in pregnancy, because I think it's really important that we think, when we're thinking about the overall effects of COVID-19, that we recognise that COVID-19 itself is potentially a relatively small part of the picture. So I will talk about the severity of COVID-19 illness in pregnancy and the direct effects of the virus on pregnant women. But I think it's really, really important that we think about what I've termed here indirect effects. and actually what are potentially bigger impacts in terms of fear of COVID-19 and changing of our health-seeking behaviours, but also the changes to care which the pandemic has necessitated. And all of these things are really important to think about as women, as partners, as family members, as employers, when we're thinking about the whole of the area topic of COVID-19 in pregnancy, and also when we're thinking particularly about decisions around vaccination, which Lucy will talk to you about shortly.
Marion, sorry, just to interrupt you. At the moment, we can just see a white screen, not your actual slides.
Apologies, I will.
That's okay. If I'll take back screen sharing for a second and then give it back to you, and we'll see if that corrects itself.
So
no, we still have a white screen at the moment, unfortunately. If you try putting your presentation into edit mode, maybe, just to see if that makes any difference.
So could you just take back the screen again?
Yeah, sure.
And try once more.
Sure. There we go. That's fantastic. Yep, we can see your slides now.
Okay, I'm just going to nip backwards to the one where I was talking to people about direct effects and indirect effects, just so that you can kind of see the scale of what I was talking about. So actually COVID-19 disease itself being a relatively small part of the picture, and perhaps indirect effects a bigger part of the picture. So over the last year, so between the 1st of March last year, when the COVID-19 became more prevalent in the UK, up to the end of February, just over 7,000 pregnant women have been admitted to hospital in the UK with confirmed diagnosis of SARS-CoV-2 infection, so COVID-19. That's about one woman for every 100 women giving birth. And what you can see from this graph are how the waves of infection affecting pregnant women very much map to the curves that you'll have seen, which are very familiar to those of you who've seen them in the general population. What's important to note is that, again, similar to the general population, only about half of women have symptoms. So actually, when we're looking at these women who are being admitted, many of them just have a coincidental positive test when they are admitted to give birth. There are some important factors we need to think about as employers when we're thinking about which of our pregnant employees are most at risk. And the patterns in pregnancy are very similar to the patterns we see in the general population. So older women are more likely to be admitted with COVID-19 in pregnancy. Women who are overweight or obese are more likely to be admitted to hospital. Women from Black and Asian ethnic groups are more likely to be admitted to hospital. And I've just put these icons at the bottom left to remind me that also women with other health conditions such as diabetes and high blood pressure are also more at risk. And what is absolutely crucially important when we're thinking about the timing of risk is that the majority of women who are admitted to hospital are in the 3rd trimester of pregnancy, so in the late stages of pregnancy. And for women who are symptomatic, that's at a median gestation of 35 weeks. For women who have asymptomatic infection, that's at 39 weeks. And that represents when women are being admitted for delivery. And this means we have to be really, really rigorous when we're thinking about our employee safety assessments, particularly for employees who are in the 3rd trimester of pregnancy, who are at greater risk of complications from COVID-19. When we think about just what the level of risk is for pregnant women, I'm looking at women here who are admitted with symptoms of COVID-19, and overall, about 18% of them, so nearly 1 in 5, need some form of respiratory support. So that might just be oxygen via a mask or via nasal cannulae, or it might mean ventilation. About 1 in 10 of them requires critical care. In most cases, that will mean admission to a critical care unit. But very fortunately, relatively few women will die. So more than 90% of women who need intensive care because of COVID-19 in pregnancy will survive. And when we look at whether those figures are very different between pregnant women and women of the same age who are not pregnant, they don't look to be particularly different. What is really different, obviously, for pregnant women is the fact that we need to think about the baby as well. And I will come on to that. I do just want to highlight that things change. So what I have very clearly seen when looking at the information, and this is based on information on all women being admitted to hospital across the UK, is that it does look as if women are being more severely affected in pregnancy since the new variants, the Kent variant, became predominant. So a greater proportion of women have had symptoms, and a greater proportion of women have needed respiratory support. Very close to my heart in the topic that, when we're thinking about women's health, is the fact that COVID-specific medical therapies are still being used relatively infrequently. So women are getting poorer care simply because they're pregnant, because of a very risk-averse culture, and I'm sure we'll all discuss that when we're thinking about the issues around vaccination. In terms of babies, what I think is often not considered when we're thinking about the equations is that around 1 in 5 of the women who are admitted to hospital with symptomatic COVID-19 in pregnancy will have a preterm baby. And we know that preterm babies, even if they're only a few weeks preterm, will have longer term, more likelihood of problems at school, for example, and may have many other health issues. So we do need, when we're thinking about the benefits of vaccination, to think about the benefits of preventing preterm births as well. Really important that I emphasize the good news messages, and what we do know from this study and from many other studies is that very few babies or of mums who've got COVID-19 infection get infected themselves. So very, very little evidence of babies having severe infection. I'm just going to come back to those indirect effects. You, I'm sure, will be aware of research which shows that mental health has got a lot worse across the whole population, and perinatal mental health is a particularly vulnerable time, and that there is no doubt that impacts have been worse. We also need to think about the impacts on women's uptake of antenatal care. Antenatal care is actually a preventive intervention. It's really important for early detection and treatment of things like preeclampsia and diabetes. And actually anything that means women are not getting the antenatal care they need, and fear of COVID is an important factor in that. It is something that we need to think about as an indirect effect. And we also know that support for breastfeeding and early pregnancy, early parenting has been decimated by the pandemic because of changes in services, and those, again, breastfeeding has long-term implications for child health. So just to summarise from me, as I say, from COVID-19 itself, around 1 pregnant woman has been admitted for every 100 giving birth. Most of those women are in later pregnancy, so that's the time when we have to be absolutely rigorous about social distancing measures and thinking about workplace safety assessments. Fewer than half of women have symptoms, but of those with symptoms, about 1 in 10 need critical care, but fewer than 1 in 100 will die. And more than 90% of the women who do have intensive care will recover. So intensive care is really effective. We need to remember the effects on babies, and particularly thinking about preterm babies, but be reassured that very few babies actually get infected themselves. And just to come back to thinking about indirect effects, which may actually have even more effect on longer term outcomes for both women and babies. This work is part funded by WellBeing of Women as well as the NIHR. And just to reflect on what Leslie said, WellBeing of Women gave me my very first research grant, so has enabled my research career. So absolutely a really important charity in the area of women's health. Thank you very much.
Thank you, Marion, for setting the scene really well. I'm just going to get my slides up. And I hope that you can all see those. So I'm going to move on to COVID-19 vaccination and pregnancy and breastfeeding. This talk could take an hour, but what I really want to do is to give a sort of high level background and then really see what this particular audience would like to ask, because there's many different directions that this discussion could go in, and so I'm going to give you a flavour of each of the different sections and then answer whatever you have and what's top of your list. One of the ways that we think of it when we're trying to consider how to what steps are needed of vaccination is, how do we identify women? How do we ensure that they have adequate counselling? How do we deliver the vaccine? And then how do we gather the data so that we can come back to showing that it is safe and effective? It's fair to say that pregnant women have somewhat frustratingly been at the back of the queue again. So in 2020, with all those vaccine trials that happened, there were none that included pregnant women. And there's a balance between saying, well, we've got to be cautious because of the fetus, and saying, well, we're left now in early 2021 with having not as much data as we would like. But there's lots that we do know. And so this is going to focus on the positives, not just the gaps. And although that I've shown it as a sort of as a line here, in fact, it's a circle, because when you get the data collection, that then feeds into working out how do we offer it effectively to other women. So who has offered the vaccine? There is something I didn't know much about until 12 months ago called the Green Book. In fact, GPs are very familiar with the Green Book because it's their sort of handbook of vaccination. And this is updated for the COVID-19 every few months. And I'll tell you now that there's an update coming very shortly, probably in this week. So I can tell you what's in the February version, but I would also say that all healthcare professionals will be watching this space and changing their practice accordingly. So the February version said that the Joint Committee on Vaccinations and Immunisations, known as the JCVI, said that pregnancy vaccination can be considered, and they picked out a couple of important groups where the risk of exposure is high or where the risk of complications is high. And in those instances, the committee felt that clinicians such as myself as an obstetrician should discuss the risks and benefits of vaccination. And it's acknowledged that there are not comprehensive safety data, but it's also acknowledged that the theoretical risks are small. So this is translated for pregnant women into these 9 groups, which I'm sure many of you are familiar with. And it's groups 1 and 2, who are carers and frontline health and social care workers. And those are the groups who are at higher risk of exposure. And then groups 4 and 6, and those are women with underlying medical conditions that put them at higher risk of complications. And Marion has just outlined very eloquently what those complications are and why these women in these groups should be offered the opportunity of vaccination. In fact, in my antenatal clinic, I also have women in groups 8 and 9, those aged 50 or 55 and over, but they're small numbers on a national scale. What you'll also be aware of is that we are moving to phase 2, and that's been in the headlines this week. So phase 2 is all people under 50, and that is going in waves, 40 to 49, 30 to 39, and then 18 years and over. And in fact, yesterday we saw the call for those who are 45 years and older to be considered for vaccination. So this is now really moving into the territory of pregnancy and breastfeeding women. And in terms of the sort of pipeline, we know that the government's ambition is to ensure that all adults over 18 are offered a vaccine by the end of July. So this is something that for the sort of here and now, and really working on ensuring that we get our vaccine coverage up very high, particularly before next autumn and winter. There are currently 3 vaccines available as of today, and I'm well aware that if I gave this talk in a couple of days, it might be out of date, but this is where we are today. So there's the Oxford AstraZeneca vaccine, which uses an adenovirus vector, and then there is a Pfizer-BioNTech US-German one, which uses mRNA, and the Moderna vaccine, which uses mRNA. In the States, overwhelmingly, they have been using Pfizer and Moderna. But the downside is that they have to be stored at -70 or -20 degrees. The Oxford AstraZeneca has the huge advantage of being able to be stored at a fridge temperature and is being used much more widely, particularly in low and middle income countries where storage at -20 or -70 is much more challenging. You'll all be aware of the in recent days of the statements on the use of the AstraZeneca vaccine. So there is an increased risk of a complication associated with the vaccine. And I'm choosing my words carefully because there is still debate as to whether it's the vaccine that makes it happen or whether it's just an association. And I know that sounds pedantic, but of course, if you're looking at trying to roll out a vaccine across this country and many others, that the words matter. And what I've highlighted is a statement from the JCVI, an extract from the JCVI statement, which says there are currently no known risk factors for this extremely rare condition, and it appears to be an idiosyncratic reaction on first exposure to the AZ vaccine. So in English, what does this mean? It means that even though the side effect that they are discussing is a clot, a thrombosis in association with low platelets, thrombocytopenia, somewhat against what you might first think, it's not women who are more clotty, more thrombotic, who are at greater risk. And the reason this is so important for pregnant and postnatal and breastfeeding women is that it's not the pregnancy or the postnatal period which is associated with an increased thrombotic risk, which is a problem for this vaccine. So we don't anticipate that the JCVI has said this, it is not related to your thrombotic risk as to whether you should or shouldn't receive the AZ vaccine. What it relates to is the slide below, which is the balance of benefits and risks. So if you look here, I've chosen the slide, these are freely available, and I've chosen the one with medium exposure. So there's a slide with low exposure, so low amounts of COVID floating around, and there's a slide with high exposure, higher amounts. And I've just happened to have chosen the medium one, where they look at the benefits of having the vaccine against the risks. And what you can see is that in every age group, from 30 upwards, the benefits really outweigh the risks. I chose the medium exposure group and the benefits still outweigh the risks. But when you get to the low COVID times, then it switches. And that is why they have suggested that for the under 30s, that they are offered an alternative to Pfizer. They've offered an alternative to AstraZeneca, which is the Pfizer or Moderna vaccine. What this means for pregnant women is that we will wait and see in the JCVI, the Green Book update, how that is translated for pregnancy. So it's not the thrombotic, the clotty status of pregnancy that's the problem. And therefore we're waiting to see how the JCVI puts their statement out. But we should note that there is much more experience with the Pfizer and the Moderna vaccines based on the states where around 80,000 pregnant women have been vaccinated. So we're taking into account the experience of the Pfizer vaccines in the states, which might, whilst we're waiting for more information, might give us an option, as we put out in the Royal College statement last Friday, to say that pregnant women should be given the option of alternative vaccines. It's a complicated matter, and it's something we are trying to upskill all the healthcare professionals so that they can explain this to pregnant women. What we're saying is that for women seeking fertility treatment, pregnant women and postnatal women, you're weighing the benefits of the vaccine, and I really would urge all of us to consider that the direct and indirect effects that Marion has outlined mean that there are clear benefits of this population getting vaccinated against the risks of the vaccine, and we're looking at one type of vaccine over another, both for the woman and for the baby. I'm clear that there is no evidence that there is a concern about fertility. And whilst we don't have definitive data on safety for the baby, there are no signals in all the data collection routes that we have to suggest that there is a concern for the baby from any of the vaccines. The Royal College did a survey which talked about why would women accept it, and it's very much as you would expect. They want to protect themselves, their family and friends, their baby, or they've got risk factors, which means that they would concern. This was around 600 women who answered our survey. And if you think about the reasons for declining, again, very much as we expect, they're worried about the COVID vaccine harming their baby. That's completely understandable. They're waiting for more information. And it's important that we listen to women and understand their reasons for hesitancy. And women said that they wanted to speak to their midwife, obstetrician, GP as their top three to get information. And that's why at the Royal College, we're doing a lot to try and get good quality information out there. This is a website at the Royal College that anybody can access. It's not behind a paywall. And so we would really encourage people to use the high quality information that we craft for this page. And there's much more on this page. There's Q&As, there's government guidance statement you can see here. And this is updated as frequently as we can get to it and need to when we see new statements. So I really flag this as a good source of information. One of the things that we've done is develop a decision aid updated 2 days ago, and this is just a snippet from it, which goes through, if you've been offered a COVID vaccine, what do you need to consider? And it comes down to shared decision making. I am not about to go downstairs to clinic and coerce women into having the vaccine. It is not in my interest ever to do that in pregnancy. But it's really important that I allow women to ask the questions and I give as much information as I can, and then we come to a shared decision making. And whereas there's been a very strong push for older adults to say, yes, really go and get the vaccine, I am still very clear that we should be offering the vaccine and providing the information so that women can make a choice, but that we understand those who are hesitant and try and provide the information that will help that choice. But given what we know, and making sure that women have that information as well. So a couple of other extra important things. There is real debate at the moment, and this is something that is a field moving quickly, about whether having a vaccination affecting work. You saw the data from Marion about what happens, say, from 28 weeks onwards, and how the risk of COVID admission, COVID complications increases. And so the advice is still that the vaccine is not 100% effective, and therefore pregnant women in the workplace should be risk assessed, consider their risk of exposure, their risk of complications, and that the employer and employee considers how to minimize the risks. This is a nice graphic from the BBC, and it's a nice piece that has appeared recently, talking about all the ways. It's no single way of tackling COVID. It's safe workspaces, vaccination, track and trace, wearing masks, washing hands, open air space, and it's that whole collection of steps that will reduce the risk of complications of COVID. So vaccine delivery is, as you are all aware, is very widely available, broadly speaking, either in hospital hubs like my own or in a GP practice, but also more widely in the mass vaccinator centres such as Excel, or even going into more novel places such as supermarkets, pharmacies and supermarkets. And broadly speaking, these are all suitable. If a woman has got a preference for a certain vaccine, she will need to consider that when she's booking for a vaccine, and that will be, we will get further guidance depending on what the JCVI statements and the Green Book statements are later this week. Marion and I both feel very strongly about getting adequate data, and in an ideal world, we would have had the clinical trials up and running and providing that. There's a document called First Do No Harm, authored or chaired by Baroness Cumberledge, which talks about how important it is to get good data on drugs and devices used by women. And this is something that the WellBeing of Women charity has been so strong on. So this is talking about mesh and hormone pregnancy tests and valproate, drug used for epilepsy, but the principles apply. And if we're going to see appropriate vaccine confidence, then we need to ensure that we are collecting data, because I go back to the circle that I showed at the beginning, which is that will help us protect pregnant and postnatal women safely. Marion has led on a COVID-19 vaccination and pregnancy study. The MHRA has been doing an app so that pregnant women can log their symptoms. Public Health England have been running a programme so that if a woman becomes pregnant inadvertently, then they report their outcomes. And there is an electronic health record linkage, which has recently started, which will help us to follow up on outcomes for pregnant women. So that all helps, along with the clinical trials that are being planned, to give us more information. Pfizer started their trial in the States, and we anticipate that it's likely to come to the UK. But we have advocated passionately for including pregnant women in research, and particularly COVID-19 research. As you can see in this BMJ editorial, my experience is that pregnant women are very responsive to taking part. They know that we have all the right ethical and safety checks to make that possible, because that will always help us to improve care and improve outcomes for women. So those are the sort of broad components of this sort of vaccination, hopefully a virtuous circle to say that we think there should be equity for pregnant women and postnatal women, so that they can have access to the same treatments as Marion mentioned earlier and the same vaccination, but that we have the appropriate checks and balances in place along the way, so that we have safe, effective delivery. Thank you very much, and happy to take questions.
Thank you very much indeed, Marion. And thank you very much indeed, Lucy. I'm sure the audience will agree with me that we've had two fantastic presentations, absolutely clear, beautiful slides, and thank you so much. And also for the very reassuring message for women in their reproductive years, really, really helpful. Sharon, did you want to start with the questions?
Please, we've had a flood of questions coming through, so I'm going to fire a number of them at you now. We are blessed with a number of male people in the audience, and quite rightly they want to know the effect on them. So those that are perhaps worried about fertility in men, what impact would the vaccine have on their reproducing fertility angle?
So I keep delving into this, and because it is a very widely a very wide concern, and it is really important that we acknowledge those concerns and do not dismiss people as those being irrational or wrong. It's important that healthcare professionals listen to that. So every time I go delving, I cannot find any evidence that the vaccine's impact on fertility for men or women. And it is surprising to me that various people in the early days of vaccination put out very effective misinformation about the vaccine and fertility, and that has stuck. And the impact of that is on that understandable vaccine hesitancy. But I keep going back and saying, I kind of want to say, show me the data to the people that are promoting it, because it just isn't there. And if people want to come back and say, Lucy, you know, this is what we can see, there is no hard evidence, and I have not seen anything. Marion and Leslie can tell me if they have. I have seen nothing to suggest there is any impact of the vaccine on fertility. What might impact on your fertility is getting sick and unwell with COVID. So it is balancing that the risks of COVID. Those of us who work in clinical settings, I've never seen anything like it in my clinical career. So intensive care units full, including with young people and pregnant women with COVID. So you're balancing the risk of that awful disease against, I think, the vaccine. Everything is saying it is safe. What we have heard is that the MHRA are on the safety checks. They publish the yellow cards. We are watching for all the safety signals, but there aren't any on fertility.
Thank you. And just touching on the impact to women, and not just those that are concerned about fertility and pregnancy, is there any impact on a woman's menstrual cycle by having a vaccine?
Leslie, do you want to comment on that?
I don't know of any. Over and above the fact that in stressful situations, women can develop irregular periods, usually because they have a problem with ovulation. And we know, for example, that subfertility and fertility problems are magnified in women who become stressed. And of course, as a fertility, someone who interested in fertility, my response is always, well, try not to get stressed. But we all know that's a silly thing to say to someone that's being stressed, because it's often very difficult to get off the wall. But I don't know of any data, either physiological or anecdotal or epidemiological data, that correlates this problem with menstrual disorders, apart from the fact that I think all of us, even those of us on the front line in healthcare who've been trying to carry on and go to work as normal, have all developed a degree of stress living in this very strange world. But I think it's so important what Lucy was saying earlier about weighing up the risks, and I would absolutely agree with her. I've been a doctor for 40 years now, and I have never seen anything like the carnage that has been in front of us in my own intensive care unit. And to put it into context, because I was deemed too old to be a volunteer in intensive care, I was put on a rota to talk to people who had relatives who weren't going to make it from intensive care. And when you're having those sorts of conversations, I think it really, really brings it home to you quite what an awful disease this is. And so please, 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 anyone of reproductive age, go and have a vaccine.
Sharon, I'm aware that it's been floating around on Twitter about the periods problem. And one of the things is that I think women have fluctuating periods. And sometimes you can start a snowball running, that you put something out, or, you know, my period after my vaccination was a bit heavier, and people latch onto it, because we all like to try and make sense of our world. But I think that I haven't seen anything that clearly says that vaccines make your periods heavy, and I don't think there's a sensible theory. I don't think there's a biological reason why that would be.
But
I think we are running out of time.
Okay.
And I was just going to ask one final question, if I may, because again, it's quite topical and for both aspects of the audience. You've spoken about, especially for pregnant women, choosing the vaccine or electing the vaccine that's right for them. What are your views on mixing the vaccines? And I believe that was again quite topical in today's media. If you choose your first vaccine, but your second, you're given a different one. What are the views on that?
I think I think the answer, as with most of these things, is it's great to see the research happening. And the announcement today is that research trial is going to be rolled out more widely, and that's the right answer. We're going to get, the more data we get, there's good reasons why the researchers are doing that work, because it may help the immune response, and that doing the trial will give us that information. And so if women want to take part, I would strongly support women, men, to go and take part in research so that we get the answers. Marion, you've got first-hand experience of taking part, haven't you? Put you on the spot.
Yes, so I volunteered as a participant in one of the first vaccine trials for exactly this reason. You know, we strongly need the evidence, and that for me is the equity argument is so important, that we must include pregnant women in this type of research to exactly answer the questions that the audience is posing, and so that I absolutely agree.
Thank you very much. I am afraid that we are out of time, and I'm incredibly grateful to Leslie, Lucy and Marion for such thoughtful insights, and thank you very much for your time today. To the audience, thank you very much for coming. I hope you found that an interesting topic. I do have a date for your diaries, and the next webinar in the series will be at 11 o'clock on the 12th of May on musculoskeletal issues working from home. Before you go, we will be circulating the recordings and a write-up in the next week, and there will be a 10-second survey as you log out. So if you have a moment, your feedback will help us with future webinars. My thanks again to Leslie, Marion and Lucy, and thank you for taking part in our webinar. See you in May. Thank you.